Go ahead.
All right, so you guys can hear me okay? I'll make sure to project for you guys too. Okay, so hi everyone, my name is Kevin Moncion. Today I'm going to be presenting some research on high intensity interval training after a stroke, a comprehensive analysis of fitness benefits and participant experiences. All right, so before we get started, I'm just going to give you guys a bit of background about who I am as a researcher. So started my journey at the University of Ottawa, and I did a Bachelor's of Science in Kinesiology. And I got really exposed to exercise physiology research and cardiac physiology research in clinical practice, specifically in cardiology clinics. I really enjoyed my time in my undergrad doing research practicums and things like that. And then I transitioned to a Master's of Science in Kinesiology, where I worked in pediatric cardiology, and I developed exercise testing protocols and things like that in kids with cardiomyopathy, so a rare heart condition. In 2018, I transitioned to a dual degree program at McMaster University. So this combined a professional physio degree with a PhD in rehabilitation science. And here I spent a lot of my time doing exercise testing and exercise training. And I led a randomized controlled trial with the McGill group here, specifically Dr. Rodriguez and Dr. Roig, looking at high intensity interval training after stroke. Also had some experience looking at some brain biomarkers of vascular reactivity and things like that, and also some clinical practice guidelines, specifically for stroke and exercise. And just recently, I was awarded a CanTrain Fellowship. This is a clinical trials platform funded by CRIR-HJR. And here I'm working with Dr. Roig and Dr. Rodriguez again, looking at a multi-site and multimodal exercise intervention after stroke, looking at cognitive outcomes and biomarkers of cognitive decline. So a trend throughout all of my training to date is around exercise physiology and clinical trials. So to get into it, so stroke is the leading cause of disability worldwide, and over 100 million people are living with the effects of stroke. And cardiovascular risk factors like low cardiorespiratory fitness, high blood pressure, physical inactivity, these are highly prevalent, and they account for up to 87% of stroke risk. And with 1 in 4 people experiencing a recurrent event within 5 years, this prevalence is estimated to double in the next 20. So determining programs that can reduce this risk is really, really important. And according to Canadian best stroke practices, exercise is a key secondary prevention strategy to improve cardiovascular health and reduce the global burden of stroke. And so much amazing work over the years has shown that exercise can enhance outcomes of stroke recovery. And there's strong evidence from meta-analyses supporting the benefits of exercise training for improving cardiorespiratory fitness, reducing systolic blood pressure and diastolic blood pressure, but also improving outcomes that are important for stroke survivors, such as their mobility, their ability to walk further distances, and their ability to walk at faster speeds. And it's important to note that these outcomes are within the clinically relevant, outcomes, and these are associated with reduced stroke-related hospitalizations, cardiovascular mortality, and also improved functional abilities after stroke. And so a key objective of, my research program to date is to ask clinically relevant questions to help bridge the gap between the knowledge to practice and implementation. So how can we take the knowledge that we know about exercise and the benefits of exercise, and how can we make it clinically relevant for people who are working on the front line, so physiotherapists and things like that? And so the first research gap that was kind of glaring to me as I was going through my doctoral work is that there's debate regarding the most optimal aerobic exercise prescription after stroke. And to address this gap, we conducted a systematic review and network meta-analysis to examine the comparative effectiveness and the superiority of all published aerobic exercise trials after stroke. And we were really excited to hear that this manuscript was recently published in the British Journal of Sports Medicine. So for those who are interested, have a scan at that QR code and you can have a free open access article. And of course, this work couldn't have been done with Dr. Rodriguez, Dr. Roig, and Dr. Ada Tang, who was my PhD supervisor at the time. So before we dive into some of the findings of the network meta-analysis, I really wanted to highlight what the differences are between a traditional meta-analysis and the network meta-analysis. And an important limitation of previous meta-analyses is that exercise interventions, so the ones on the red box on the left, they're often combined into one group to streamline a comparison between an exercise and a control group. And now in the context of stroke, there are now many published RCTs that have shown different treatment effects. And so the benefit of doing a network meta-analysis is that it can bridge this gap by comparing all the available RCT evidence into different exercise interventions. It can also provide a rank order of treatments from least to most effective. And a huge advantage to this approach is that it allows for multiple comparisons, whether they're direct, so the black lines, the black thick lines there, and this red line here that you can see animated on the slide. And this provides us insights between RCT evidence that is compared directly, but also exercise interventions that have yet to be compared in a traditional randomized controlled trial. And when we're looking at this figure, the size of the circle, so that's called a node, that represents how many studies are within that node. And the thickness of the black lines indicates the amount of comparisons are within that comparison. So here in this slide, we see the primary outcome of our study, which is peak oxygen uptake, so cardiorespiratory fitness outcome. And we see a forest plot. And on the y-axis, we have treatment groups. And then on the x-axis, we have mean difference relative to the usual care. And the dashed line in the middle is the null line. So there's no difference. There's no effect when it crosses that 0 line. And here we found moderate certainty evidence that high-intensity interval training yields the greatest effect on fitness, followed by both high and moderate intensity continuous training. And when we're looking at MCID, so minimal clinical important differences, it's important to highlight that these improvements here are all within the clinically important benefit range, which is really important. So here in this slide, we have a panel of 4 sucra plots. And on the y-axis, we have the sucra score. So a higher sucra score value means that it has a higher probability that a treatment is best ranked or top ranked. And then on the x-axis, we have ranking of treatments. And here across all 4 major outcomes of interest, so peak oxygen uptake, blood pressure, walking distance, and gait speed, high intensity exercise training, whether it's done in intervals or continuously, are the highest ranked interventions compared to kind of previous standards of care. So taken together, the findings from this network meta-analysis suggest that high-intensity aerobic exercise, whether it's done continuously or in intervals, are the most superior interventions for improving fitness, blood pressure, and mobility outcomes after stroke. As we identified in our network meta-analysis, we identified that there's a growing body of literature supporting the benefits of high-intensity interval training. And these trials have shown quite a bit of promise and are preliminarily quite effective. But when we're examining these on closer investigation, there were some limitations. So most trials were not time efficient, so they were quite long in duration, and they weren't progressive in nature wow, geez, to tap into those progressions and those benefits in exercise. And there's also quite a quite a few studies that lacked post-intervention follow-up. So there was quite a few gaps still. And to address these gaps, we conducted a CRIR multi-site randomized controlled trial that explored the effects of 12 weeks of high-intensity interval training versus moderate-intensity continuous training on cardiovascular and mobility outcomes after stroke. And this protocol was published in Trials in 2022, and we just published this paper in Stroke in 2024. And again, this work couldn't have been done without the help of Dr. Roig, Dr. Bernat de la Harris, and Dr. Roig and Ada Tang. So big team effort for this one. So here in this trial, we screened 305 participants and 82 participants were randomized, 42 to the HIT group and 40 to the mixed group. The mean age in this sample was 64 years old. 32 participants were female, so roughly 40% were female. And the timing since stroke was 1.8 years after stroke. And for those of you who don't know what high-intensity interval training is, we followed a short interval paradigm, which included 10 one-minute intervals of high-intensity exercise, interspersed with 1 minute of active recovery. And this protocol was progressive in nature with the goal of exercising to 100% of maximum effort during the exercise bouts by the end of the intervention, by the end of the 12 weeks. And in contrast, our moderate intensity continuous training protocol followed a traditional approach. And this involved 20 to 30 minutes of exercise at moderate intensity with the goal of exercising continuously at 60% of effort by the end of the intervention. So both groups had a 2-minute warm-up and a 3-minute cool-down period. And it's important to note that the high-intensity interval training group was about 20% more time efficient. So here in this slide, we see the figure of our primary objective again, which is peak oxygen uptake, which is the gold standard measurement of cardiorespiratory fitness. On the y-axis, we have peak oxygen uptake, and on the x-axis, we have the study time points. So from baseline to 12 weeks to 20 weeks follow-up. So the red groups, the red circles here are the HIT group, and the green circles are the mixed group. And the primary question of this paper was, does yield grade better effects at 12 weeks compared to the control group? And here we found a significant between group interaction, showing that high intensity interval training yields a 1.8 mil difference compared to the mixed group. So that's quite a significant difference there. The second question of the paper was, are these benefits sustained over time and after an 8-week period follow-up period? And here we found that only the HIT group had a significant increase at the 20-week mark, and this was a sustained increase of 1.7 mil. So again, showing that high-intensity interval training is superior at the 12-week period, but it also has long-term follow-ups, benefits at long-term follow-up. And similar to our network meta-analysis, it's important to highlight that our benefits here are within the MCID range, and this shows clinically important differences and benefits. So the key point of this trial was that high-intensity interval training may be a time-efficient alternative for promoting clinically meaningful changes in fitness after stroke, immediately after intervention, with clinically meaningful benefits that are sustained 8 weeks after training. Now, the last thing we wanted to look at is, what do people post-stroke think of HIT? There's a lot of conceptions from physiotherapists and other healthcare providers about what they think of HIT, but what do the people that are actually doing it, what do they feel? Do they think it's suitable? And so another study that we conducted was a qualitative study. This was a little bit outside of my wheelhouse, but basically here we conducted qualitative interviews with stroke survivors from our HIT trial. And we wanted to get an idea of their perspectives of doing high intensity interval training so that we can develop training programs that are suitable for them in the future. And this paper is currently under review at Disability and Rehab. hopefully it gets published soon. And so we interviewed 9 participants. These participants were on average 60 years old and 2 years post-stroke. We followed a maximum variation sampling of 2 to 1 female to male recruitment strategy so that we can get more participant perspectives of women in this trial, because women tend to be underrepresented in research. And we identified 3 key themes in our data analysis. The first theme was valuable learnings through the HIT program, integrating HIT into an exercise routine. And the last theme was the rewards of being pushed outside of your comfort zone. And so many participants viewed HIT as a highly beneficial and physically rewarding intervention, leading to expected improvements in their cardiovascular health, in their muscle strength, specifically in the lower extremity, and their improvements in their fitness levels. For example, the reward with HIT is that you become more confident and that you improve. And I think when people see that they're improving, they get more confident and they get more daring, and then they do more things. So it's a snowball effect to say, yeah, I can do this. So this was a participant who was 64 years old in our study. Participants also described learning valuable lessons throughout the HIT program, including that maintaining exercise behaviors requires discipline and commitment. So for example, HIT has to be a part of me now. It absolutely has to be. I was given a second chance from not being able to walk to walking and running and doing activities of daily living, driving, and other stuff. It has to be a part of my life. It absolutely has to be. So a pretty striking message there about valuable learnings throughout the HIT program. Lastly, participants also described the importance of having guidance from friends, family, healthcare professionals to help support the adoption of HIT out in the real world. And many described that having personalized exercise programs can be helpful in suiting their own needs. So for example, a participant who was 55 years old post-stroke, I'm not confident in when I can progress to the next level. I don't have any way of knowing. Am I doing well? I feel good, but at what point do you move to the next level? I need someone to say, you've been there too long. Now we're going to move you on to the next level. I just think there needs to be more tools for them. And so to round out the findings of this research, I'm sure you can appreciate that individuals with lived experience described engaging in this intervention, so high intensity interval training, as a highly rewarding intervention after stroke, but they definitely need more support to promote this type of intervention in everyday life. So throughout this research, I've laid the groundwork to help bridge the gap between knowledge and implementation. And the findings of this research reinforce that high intensity interval training is not only clinically effective, but it's also an efficient and rewarding intervention, as reported by people with lived experience. And as a clinician, but also as a scientist, I recognize that there's a lot of areas for future research. And there's an important next step in updating and adapting clinical practice guidelines to include careful screening for high intensity interval training after stroke. We also need to develop co-designed interventions for people with lived experience, and we need to include them in our clinical decision-making when we're doing so. And I'm going to end off this segment here with this quote that I find quite powerful. So if I didn't do HIT, maybe I wouldn't be the same man with my grandkids, following them everywhere. I can play with them, and I think it's great stuff. So this powerful statement captures the motivations behind the pursuits of doing this type of research as a clinician scientist, and it highlights not only the importance in clinical improvements, but also the broader impact that we all have on these people's lives, and specifically the role of exercise on making such a big impact. And so what's next? So doing a postdoc at McGill with GRH, and we're doing a bunch of cool stuff, more novel interventions. We recently got funding to conduct another randomized controlled trial after stroke. This is in collaboration with Dr. Rodriguez and Dr. Roig and other sites across Canada. And here, this is just a slide showing cognitive function on the y-axis, and then I guess a timeline on the x-axis, so timing. And in somebody without stroke, there's a typical cognitive decline in people in neurotypical individuals, and there's a slow rate of decline over time. Now, this trajectory is, of course, very different in people post-stroke. So typically, when someone has a stroke, there's a really quick, acute decline in cognitive function, and this tends to persist and get much worse as time progresses. And up to 70% of stroke survivors experience some level of cognitive decline. So this is a pretty significant number considering there's millions and millions of stroke survivors worldwide. So the idea behind this study is, what can we do to maybe alter this trajectory of cognitive decline? And here we see that multimodal exercise training appears to be kind of the most effective intervention for improving cognition. And this is a meta-analysis that was conducted in 2017 by Oberlin and colleagues. And they synthesized all the evidence looking at aerobic exercise versus combined versus static and balance exercise. And they found that overall, exercise is good for cognitive impairment. But when they do a subgroup analysis, so when they disaggregate these different interventions, they see that the combined training, so the training that includes resistance and aerobic exercise, tends to yield the greatest benefit for improving cognitive function. But like all research, there's always gaps to these and limitations to the evidence. And so we're adopting a novel intervention here early after stroke. So we're looking at the subacute phase of stroke, so anyone between 0 to 6 months post-stroke. And we're comparing multimodal training that encompasses traditional resistance training and aerobic exercise training to a control group of just a usual care paradigm, so participants that are undergoing balance, toning, and stretching exercises. The primary outcome of this trial is cognitive function, and this will be measured using the ADAS-Cog plus 13-item cognitive battery. Then our secondary outcomes will be the key biomarkers for post-stroke cognitive impairment. So here we're going to be looking at amyloid beta and tau protein plaque accumulation. We'll be doing neurodegeneration biomarkers, so neurofilament light. We're going to look at chronic neuroinflammation in the blood-brain barrier and how permeable it might be after a stroke. And then we're also going to look at cerebral perfusion, so cerebral blood flow in different structures that are involved in cognitive function. And the goal of this training is like I mentioned, is to try to stave off the cognitive decline that we often see in the early phase of stroke recovery, so that they get to a more neurotypical trajectory over the time course. So that study is currently underway, and we're in the planning phases. Currently applying for ethics approval, but it's a trial that's going to take place here and at McGill. And then we're going to branch it off to other sites across Canada. And it's a very exciting trial because we're the first ones to look at the key neurodegeneration biomarkers after stroke and how they might be related to this potential improvement in cognitive function. And so to wrap up, these are kind of the key points of my presentation today. So high intensity aerobic exercise is the superior intervention for improving cardiovascular risk factors and mobility after stroke. High intensity interval training may be a time efficient alternative for promoting these clinically meaningful changes in fitness. Individuals with lived experience describe engaging in this intervention as highly rewarding. And the next step is multimodal training may stave off post-stroke cognitive decline. And that's it for my presentation today. Happy to take questions. Yeah.
So thank you, Kevin, for your presentation. I think we should start with questions on Zoom, maybe, or so I will mute myself, Kevin, and then if you see questions on the chat or people ask questions on Zoom, you're welcome to ask questions on Zoom. If you can repeat the question and
Yes. So far, there's no questions.
I have one too.
Perfect.
okay, we have questions in the room, so no questions on Zoom?
No questions yet.
Yes. Yes.
It's really the high intensity one. So in this last one, it seems to be moderate.
Yeah, moderate to high. Yeah. So when we're looking at the previous trials that are already published, the best benefits we're seeing are studies that are progressive and that target eventually a high intensity effort. So yeah, like I would say, especially early after stroke, it's probably not ideal to push them right into high intensity within 0 to 6 months post-stroke. You want to train them a little bit so they become a bit more adapted. And so the rationale there is to kind of get them up to speed so that they can progress eventually to the high. No, I just unmuted like a few minutes ago. Yeah.
And strength training doesn't matter. You're training both the effective side and non-effective side. You're getting both.
Yeah. Strengthening both sides. And I think a key point is that all the training will be individualized to their I guess their abilities.
Yeah.
So we'll be doing basically 1 rep max testing, things like that, to see like how strong they are at the beginning so that we can individualize their programs. But it's whole body. Yeah.
You think multimodal, like or functional resistance training will have more effects on condition? Because we're debating that we don't know if we do pure resistance training, which is just resistance training, or we do more like more functional or coordination movements that maybe are not don't have the same effects on the muscle, but maybe at a cognitive level, there is a bit of evidence that if we do more complex movements, this may have a bigger impact.
Like the visual motor task.
Yeah. We're still deciding on exactly what kind of resistance training.
Okay, I was asking Anouk as an expert in dual tasks and if because we're still deciding on the resistance training approach that we want to use, and we have 2 options. One option is to do pure resistance classic training, like the one that you saw, that you see now on the slide, or do a more functional type of training in which maybe we don't work with the same resistance. It's going to be lower resistance, but it's going to be more challenging in terms of coordination, all these kind of things, because we believe that maybe this will have more effects on cognition.
I just want to follow up with that to mention that more important actually is the cognitive load. So you mentioned dual or multitasking, but the inclusion of a cognitive load may be more important, no matter what kind of other modes you're doing. So that combo multimodal training should include the cognitive component.
That is going to make the control group a bit more challenging.
Yeah.
Sorry, everyone, but we have questions on Zoom, and I think we should.
Okay.
You want to read them, Kevin, or you want me to read them?
I
The
just-
one in French, I'll translate it for you. If you scroll down, it's translated. This
Yeah.
is the first question from Eric. Thank you, Eric.
Kevin speaks French very well.
So where is this
really?
question?
Yeah.
Sorry.
I don't see it. The French question.
It's the first one. Oh, it's to me. Okay. Well, basically, Eric was asking, it has been mentioned that interval training should be based on the reserve heart rate. So what test, protocol, and device should be used to measure the maximum heart rate? Also, if the patient has already performed a stress test, for how long is used valid? I'm translating. Also,
No,
during training, should the stress perception scale be used?
Yeah, great questions. So I guess to answer your first question, you're right. We use a combination of heart rate reserve and ratings of perceived exertion to prescribe our high intensity interval training protocol. And we used a cardiopulmonary exercise test with gas exchange. So we had VO2 data to be able to prescribe that as well. In terms of the usefulness of a exercise test and how long ago you can use that test, I think it kind of depends on if anything's happened with that patient in the meantime. So if it's, weeks and everything's status quo, then I think you could still use that test. If it's years and there's been repeat strokes or new comorbidities that are kind of have a new onset, then I think then that test is no longer valid. So I guess it kind of depends on how recent and if anything changed in that time.
Can I add something? I mean, physiologically, if you do a stress test today and this person stops to exercise, the VO2 can go down very quickly in weeks. So if the patient continues to train, I think 3 weeks, 1 month will still be valid. But if the patient stops training completely after the stress test, the VO2 peak that you obtain probably is going to go down. Okay, so yeah.
Question. Can I go?
One second.
Okay, yeah. So Véronique, so the parameters for high intensity interval training for subacute stroke are yet to be determined. So that is something that needs to be done. Most evidence is in chronic survivors, so 6 months post. So I can't comment specifically on or provide recommendations on what the parameter should be for subacute stroke, just because it hasn't been done yet in research.
Is it good at 80, 90 years old?
Oh, I saw that one. Yeah.
Yeah.
Yeah. So in terms
So sorry, the question on Zoom is it good at 80, 90 years old with a lot of conditions?
Yes. Yeah. So that's a great question. So when we do our exercise screening, we do a questionnaire. So you could use a PAR-Q questionnaire. You could use a cardiovascular risk stratification questionnaire. And basically your decision making will have to be based off of how the person screens. So depending on the types of conditions, it may not be safe and feasible. So it's a very individual approach. Maybe that 80 to 90-year-old patient, maybe they won't even want to participate in high intensity interval training, right? So maybe a low to moderate intensity is safe and effective. Like we showed in the network meta-analysis, you're getting similar improvements between moderate to high intensity interval training for fitness gains. And so if moderate is safer for an 80 to 90-year-old, then I would probably stick with that.
May I add something? So we don't have data for subacute stroke, but you have a bunch of data in cardiac, patients.
Yeah, true.
And when they compare moderate versus heat, there is no difference in the risk of adverse events.
Mm-hmm.
I'm not saying you don't have to do things well clinically and screen them and make sure they don't have contraindications to exercise, but it doesn't seem that heat, exposes the patient to a higher risk. We have huge studies, wrong studies, from 5,000 people, cardiac people that had a heart attack, and using heat versus MICT, people using heat, they don't have more adverse events. So
Yeah.
we need more data for a stroke, but my feeling is that it's gonna be as safe as what we show in the chronic stroke patients.
We move to the questions. There is one last question that says, how do you envision having cognition as an outcome measure in rehab? Usually, it is okay. It's okay. It's OT that does specific cognitive retraining. It's not Ali who is asking this question, but it would be in PT or KIN that multimodal training can truly be implemented as a modality. But we aren't qualified to use cognition as outcome measures.
Yeah, that,
That's kind of with that. But so-
oh, that was you.
Yeah.
Oh.
So it's just that
Good point.
basically like, yeah, like in OT, go through a lot of like very specific like cognitive rehab that doesn't necessarily include physical activity.
Right.
But then in physio or kin, we'll do a lot of physical activity without using cognition as an outcome measure. So
Right.
do you expect this to be translated into practice with kind of more of like a team effort? Well, let's say the team goal will be to improve cognition in some way, and then everyone kind of works on it on their end, because we've never, like, as a I've never had cognition as an outcome
Yeah.
for me, you know?
Yeah, for sure. Yeah, so you're right that cognition is not typically an outcome we assess in clinical practice as physios. I think the idea we have is that if we can improve cognitive outcomes using other means like multimodal training, for example, then maybe that patient can get benefits from both PT from a cognitive lens, but also from OT from more of a traditional cognitive lens, right? Traditional cognitive rehab processes and things. That's kind of my take. Like if you can both improve the same domain using different approaches, I think that's great, especially early after stroke.
In the study, we're gonna control for what they do with OTs because some of them will receive cognitive training
Yeah.
and we'll have to control for them.
Yeah.
Cognitive problems after stroke are neglected by research and we don't have good therapies yet to improve them. So that's one option.
That answers your question.
This study was done with the new step machine.
Yeah.
So what I see clinically is when they're out of here, the new step machine is not available in most gyms.
Yeah.
So stationary bike, treadmill, elliptical, I can show them how to do it on any machine.
Yeah.
No matter like.
Yeah. I think the same principles apply, especially if you use RPE, ratings of perceived exertion. In a qualitative study, I didn't say all the quotes because I'd be reading for days, but some patients actually adapted the HIIT protocol to everyday life. So I had a few participants say that when they did their standard walk, they would just pick up the pace for a minute and then they would decrease the pace. And so I think just teaching them different ways to incorporate, I guess, intervals in a way is a good approach. I don't think it needs to be like new step only. There's, I think, benefits for bike that's been done in research. Treadmill's been done in research. I think the next step is like a real world implementation trial to see how they do it in real life. Even stair climbing is a great, if they're able to do that, stair climbing is a great thing that you could do at home if you have stairs or in the community to increase your heart rate and effort. And typically it's short. Yeah. Hi.
Are you considering any in the proposed
Yeah. Yeah.
Are you considering any mental health outcomes?
$100%.
Can you
Yeah.
repeat the question a little bit?
Yeah. So the question was in the proposed RCT, are we going to be accounting for or assessing mental health conditions? And so the answer is yeah. We're going to be looking at depression scores. We're going to be taking a look at fatigue as well. Those two things are typically quite linked with cognitive decline and cognitive function. So those are the two major mental health, I guess, concerns that we're looking at. Do you have any other potential suggestions? Anxiety? SS.
This could also be very important having effects on the cognitive functions.
Yeah.
So to be taken into consideration.
Yeah, no, absolutely. That's something we'll consider for sure.
Yeah,
Yeah.
And so from the first project that you did.
Yeah.
You were saying that the planning to involve. Development. So have you done it for this trial?
Not quite yet.
Sorry.
That is something that I believe we're gonna get started. I think a huge aspect is tertiary quaternary outcomes to see if we can include I guess patient-specific outcomes that they find are important. I think that's like an additional thing we should consider, but also whether the training is feasible. So we've had preliminary discussion. I think we've had preliminary discussions with patient. Maybe I'm mixing it. Yeah. Yeah.
It's pretty really focusing on.
Mhm.
So it's pretty much the same in myself. That's kind of the thing. But of course, they're putting on something. What are trials so as incorporated.
It's okay. Yeah. Yes. So my question is really about the qualitative analysis that you did.
Yeah.
So was it like open-ended interview questions with certain core questions so you can analyze certain themes later on, or how was it done?
Yeah, so it was a semi-structured interview that was built off of a theoretical domains framework, which is a common framework that implementation scientists use to develop programs in the future. So it's a good kind of initial step to get, I guess, insights on what are some things that impact implementation. So questions were based off of that theory and open-ended. So if a participant wanted to expand or provide additional details, they were free to, and or if a conversation was going in a different direction, that was also okay. So it was pretty open.
And then the thematic analysis?
Yeah, thematic analysis was done on that. Yeah. Yeah.
Sure.
Please.
I have two questions.
Yeah, sure. Yeah.
The first is, to what extent is motor impairment like a limiting factor for a hit?
Yeah.
If I had one of my legs was paralyzed,
Mhm.
I don't think I could achieve 90% heart rate, for example.
True. Fair enough. Yeah. So that's a great comment. The exercise tests take that into account. And so if someone has an upper limb impairment or a lower limb impairment, that'll limit how much they can do on an exercise test. And that's how we prescribe the program off of. So say you reach like 100 beats per minute on the test, that's your capacity. Then we would take 80 to 100% of that. And then that's what the program would be based off of.
But if they're very weak, they may not be at the lactate threshold
Yep.
or whatever, right?
Yep.
It may be just
So they would hit, typically we see them hitting lactate threshold very early because they're
Okay.
so unfit. And so typically you're still getting that anaerobic metabolism kind of kicking in. Yeah.
Add something. Sure. I don't know if you know the new step that we're using.
Yeah.
You know, so the new step. The question is great, and I think that's a challenge. But the new step allows people with to work only with one side of the body. Still, of course, they're gonna probably not reach the full potential if they could use both. But that's one of the advantages of new step that allows even people with this kind of patterns, they can still use.
okay.
So it's a great machine. It's fun.
Yeah, it's slightly adaptive. Yeah.
Okay.
Yeah.
My second question
Yeah.
had to do with what's your cognitive outcome, your
Yeah.
main outcome of the RTC?
Yeah. So it's the ADAS Cog Plus. So it's a
Okay.
13 item battery of cognitive assessments that gives you kind of a score. And from there you can see whether someone has cognitive impairment or not.
You Yeah, you just might have to be careful because in stroke, the global cognitive measures are not always really valid
Yeah,
because you should
100%.
have a specific language or
Yeah.
attentional impairment
Yeah.
due to the lesion location, right?
You
Yeah.
can obtain the name specific,
Yeah.
and the other
Yeah.
score, we have the global score, when you have executive functioning, language specific domains that you obtain.
Okay.
Yeah, you can split it up. Yeah.
It is challenging.
Okay. Yeah. Great.
Yeah, thanks.
Well, first of all, congratulations.
Oh, thanks.
Very nice job and presentation.
Thanks.
I'm gonna build up of the question of Madura and
Okay.
Dimitri.
Yeah.
So the first one, do you have cutoff to including people with cognitive issue? So you're gonna enroll any people regardless of the cognitive score of baseline, or you're gonna exclude someone based on that?
Yeah, so great question. So for the prospective study, we're going to be excluding people who have a probable diagnosis of dementia. But we're not cutting anyone off from the ADAS-COG.
That's a great question. That's a great question because one of the issues is what if you had dementia before you had the stroke?
Yeah.
That's a big challenge in this project and it's very difficult. So we're using a questionnaire. So we're going to ask proxy, so family members of the patient to come here and to fill out. It's not perfect, but it's the best we can do because you may have a stroke, but underlying the stroke, you may have MCI. So we have MoCA, we're going to use the mini-mental, but we will not exclude them based on that. But we're going to use that proxy measure to get a sense. And if we feel that their memory has declined before they had the stroke, these people probably will not be part of the study.
Yeah.
Okay. Thank you. And the second, sorry, go ahead.
Yeah, I was gonna say, you had another question.
Yes.
Okay.
The second question is, in the interview that you have done with your participant, do you have any also information about the more continuous type of training? And yes, they were telling you that they love the program and it's the same with the Parkinson that I'm seeing, like they love the program. But when they come back here at the tool, you really see a fall in their fitness as you did and so in your trials.
Yeah.
So although they're able to still exercising, they are not able perhaps to eat the same target.
Right.
Do you have any solution for that, or how they could be helped with that? Thank you.
Yeah, no, yeah, great comment and question. I think the follow-up period is tricky, right? So it's hard we know adherence and self-management can be a concern with people with comorbidities. And so that's a huge area for future research. So you get them exercising in a controlled environment. How can you get them to continue in the real world? And I think that's like a next step. So it's hard to say. We know, like I said, adherence issues are a concern, and declines do happen quite rapidly in exercise interventions. So it's kind of a next step, I would say, is to figure out what can we do as clinicians to kind of keep them fairly active so that they, keep their benefits basically.
How many questions we have? If we tell you a question.
Yes, my question was just about the safety.
Yep.
You answered that.
Yeah.
But because of as like new clinicians, we might be a little bit conservative in exposing people after a stroke to more high intense training.
Yep.
So in your experiment, did you face any kind of adverse reaction during the training?
Yeah, so great comment. And it's I think it's a fair thing to be, I guess, cautious in the initial phases of rehab. So we did not have adverse events. And that is fairly common across the board. Like we're currently doing a meta-analysis synthesizing the adverse event rates. And it's like 0.2 per 100 sessions. Very, very, very small. And that's compared to standard care of MICT, moderate intensity continuous training. So there's no difference there. The key aspect though is that a lot of the evidence is in 4 to 4 months greater. So there's nothing really early. So that's the next step. But I always like to bring back this slide, and this is the slide showing the benefits of training. And if you look at these, sorry, I'm just gonna make this small so you can see. If you look at these, these these ones here. So this is moderate intensity continuous training. That's high intensity continuous training, and that's HIIT. They're all showing very similar benefits. And so we know in subacute rehab, moderate intensity is perfectly fair game. There's been so many trials looking at that. And so if you can get a subacute patient to do moderate intensity continuous training for like a 1 or 2 weeks and they're improving and they're getting better, then I think it's fair to progress them to HIIT. But again, it's a progressive thing. You don't need to jump right to high intensity interval training in rehab because you can progress. You could do a progressive approach, and these 3 programs are great. Now, what's interesting is if you look at the null line, that's usual care. And so what I like to point out on this graph is that what usual care is doing for fitness and other outcomes is quite minimal, and nothing compared to no exercise, right? Like it's very similar to doing absolutely nothing. And so I always say, like in the subacute phase, try to do moderate, progress to HIIT and those types of workloads to get better benefits, basically. Yeah.
I just want to add that this is not about safety, but in the same trial that he presented, we look at enjoyment and motivation of patients, and we compare HIIT versus MICT.
Okay.
And we didn't find differences. So both are equally enjoyable or motivating. This is going to be published very soon. This is part of Lyndon's PhD.
Cool.
We found that the effective response in the beginning of the session in HIIT is a bit worse. So you probably as a clinician should be ready to convince the patient not to drop the ball and to keep training.
I see.
But no differences in enjoyment and motivation.
Cool.
So with that, so part of the, even as part of that same paper, we want to
to add on that, with the, I guess these are psychosocial responses and how people, if you want to encourage adherence, some things that we identified also saw, you probably see them in the same, like similar themes in Kevin's paper, but also in other qualitative like reviews or studies with HIIT, is that there are kind of themes about like you want to support their feelings of competency, their feelings of mastery over the exercise they're doing, the relatedness. So with another person so we had a trainer who was 1-to-1, so you might have personal relationships that form. So these things are also important to support.
I see. But the overall adherence, it's inferior in the HIIT than in the MCT.
No, we have
No.
difference.
Okay.
Adherence was great.
Okay.
Yeah,
nice.
yeah. 82% of everyone attended. Well, sorry, there was an 82% attendance rate.
That's
and
a
adherence.
trial. Maybe in real life,
Yeah.
people will not exercise at the same intensity because they don't have a personal trainer.
Yeah.
Sure.
Waiting.
Yeah, I mean, we did a really good job in the trial keeping people and providing support so people felt like they could exercise at a high intensity. But yes, that's not something that's feasible for everybody to implement, right? So I think the important things though is that some lessons that we can take from the trial can be, so like just the way we structured the trial, the constant encouragement that was consistent, those things can be provided. Depends on, well, it remains to be seen how it's implemented.
True.
Context.
Yeah, interesting. Thank you.
Yeah, no worries.
There's a
Oh, is there?
Yes, please. Now, we're gonna go for that one on Zoom and then do next. Yeah, no, sorry, only to me.
So
Okay.
the question is from Nicolas Rodaros. Not sure if you mentioned it. If so, can you repeat what was the work to rest ratio of the HIIT sessions, where as well as the duration and frequency of the sessions?
Yeah. So this is that slide. So it was 10 bouts of 1 minute at high intensity exercise interspersed with 1 minute of active recovery. We trained for 12 weeks, 3 times a week on alternating days. So that was the fit parameters.
On the slide before, right, you showed that the moderate intensity continuous training, it worked pretty well in the clinical period. And I see how hard it is to do the HIIT in the training. So for follow-up, like you do a training period, makes sense to do HIIT because it's outside, it's even better. But couldn't follow-up just be moderate intensity continuous training and like for the rest of your life? And then you probably get much more uptake of it clinically?
Yeah, I mean, that's a fair comment.
It's a question. Is
You know,
it-
No, yeah. It's a fair point. I think if something is easier to implement, moderate intensity continuous training, then that's fine, and that's just as effective. I think when it comes to clinical practice, there's often time constraints though, and so moderate intensity continuous training tends to be much longer in duration.
But they
So
could do it on their own, like when they're discharged, because this is
Right.
when they're acute.
right.
But I think just the like to your point, if you want to keep them to continue exercising, this actually came up in my thesis defense, was that the intervals that we're introducing are a way to break up the monotony of a moderate intensity training program and kind of maintain the same intensity for 30 minutes, 40 minutes, whatever. So that interval is also, I think, a factor or an important component to keep the people exercising. There's enjoyment there, and I think that breaks up why exercise could be boring if you're doing constant exercise, low intensity body exercise.
Yeah.
So I don't know if there is data on this, but does stroke location determine how much cognitive or the risk of cognitive decline that people might have? And if so, are you going to?
PFC. I can say it'll be.
Okay, so are you going to control for that, or like, because some people, depending on their stroke location, they can decline faster than some other people in your trial?
Yeah, I think it's something that we'll do.
It's not just stroke location. There's evidence that stroke itself is a risk factor for development of Alzheimer's disease, for example.
Right.
So the biomarkers, that's my question, is elaborate on the biomarkers and like what time points you assess and how sensitive is it to
Yeah.
biomarkers.
Yeah, no, it's a great question. So, yeah, one thing I didn't mention for the sake of time was the study duration. So it's a 12-week intervention with a 1-year follow-up period. And so you're absolutely right, like stroke can definitely be a kind of a risk factor for developing future cognitive decline or cognitive impairment. And so we have data right now in our funds. We have data collected at baseline, at the end of the 12 weeks intervention, and then at a 1-year follow-up. So we have 3 time points to determine trajectories over time. Hopefully we get more funding and then we can add a 3, 6, 9-month time point for those biomarkers. Very expensive to run these things. That's the downside. And so a lot of these biomarkers are I guess known predictors of cognitive decline. And the idea is if we can change these biomarkers with exercise, so that delta, is that delta going to be predictive of someone's impairment in the future? So hopefully we see that you have lower biomarkers after exercise and better cognition. And that is kind of the trajectory over time. That's kind of
Before
you going to
one
control
second,
the
what, Joyce, 1 second before you continue, because I see people on Zoom are leaving.
Yeah.
So I just want to thank everybody for attending, and I'll see you all in our next talking research.
But how are you gonna?
I'm just gonna, did you want me to get off the Zoom?
I'm basing it off from Bernard's.
Okay. I'm sorry, what?
How are you going to control for this heterogeneity? What is the sample size?
It'll be about 100 participants.
So you think it's gonna be enough to perhaps do subgroup analysis based on the stroke location?
Probably not. No.
There's no need if the biomarkers are sensitive. Because you have your control group that you're going to monitor.
Yeah. Yeah.
Sorry, one thing is the cognitive assessment. The other thing is the biomarker. So for biomarkers, we use neuroimaging, so blood barrier permeability, CBF. And then we have blood biomarkers, which are axonal, neurodegeneration, tau, all these can be biomarkers, and we expect to change them with exercise and see that this change protects the brain. In the subgroup analysis, we have the analysis that you're talking about. My feeling is that this is gonna be underpowered.
Oh, yeah.
Like in any stroke trial, probably every time. Because it's very difficult to, unless you have thousands of things.
Yeah, that I would say like the stroke lesion subtype stuff, I would tend to say that's probably best answered with like a cohort study, longitudinal cohort, like large scale, like UK Biobank data analyses. With a trial of 100, like you won't find any, and if you do, it'll be type 1 error.
Yeah.
Like it won't be like a meaningful finding, I don't think, personally.
I see that somebody has a question.
Yes.
Yes, just to follow up.
Yeah.
On biomarkers.
Yeah.
It couldn't come from Parkinson, so maybe it doesn't apply, and I don't know.
Yeah.
So now there is a lot of discussion and debate whether Parkinson pain are a causal or bystander.
Oh yeah.
Sometimes you find them in healthy participants.
Yeah.
You measure them one day, you measure them the day after they are not there anymore, or maybe they are here.
Yeah.
So how much cheap are you betting on beta and tau?
Yeah.
And do you think they're gonna be really the mechanism behind the current development of the machine?
Yeah, so the beta and the tau plaques are that's like the strongest biomarkers with Alzheimer's disease, and those are, I guess, the strongest biomarkers in terms of relationships between cognition and like structural decline and things like that. So I would say, like, whether that is responsive to exercise, I think there's some association evidence there. In terms of trials, there's not much in terms of stroke to comment on, you know, if our changes will be for sure inducing those improvements in biomarkers. But those are, in other research like dementia, Alzheimer's, they're the strongest biomarkers, I would say. Yeah, that predicts cognitive decline. Yeah.
Are you thinking about sleep as well? Because exercise helps sleep, and sleeping better changes cognitive ability. So you may find it helps, but maybe it's just because they're sleeping.
Yeah, no, it's a great question. So I think in a perfect world, we would give them accelerometers that they can use to monitor their sleep activity. Yeah, in terms of sleep assessments, that's a whole other branch and they're very complicated. But I would say, like, if we can, we would give accelerometers to monitor sleep duration, sleep quality. Probably not the best, it's not the gold standard, you know that, but it could provide some. Yeah, questionnaire could work too.
Could we use actually use the PSQI, like a Pittsburgh sleep questionnaire in the previous study. We haven't looked at the data though, but it's not easy to do. So
one thing that Kevin didn't mention is that we're gonna try to use transcranial Doppler too in this study. I need to buy it first. I need to find money to buy it, but the idea, because we expect that some people will not like to go scanner to do the imaging. So as you can see, this project is already quite charged. So I don't see, doing polysomnography for this one. so we're gonna probably use actigraphy if we have, or we're gonna use questionnaires, but it's gonna be a secondary.
You're gonna hate me. Are you gonna screen for apraxia? Will you include people with mild apraxia?
I think we will.
Yeah.
So in that case, the apraxia score.
No.
Like they're truly.
Okay, good to know.
But based on the because I had two things in my head. Actually, sleep also affect amyloid beta.
For sure.
So, but based on what he was saying, I think, are you going to try to, I mean, this gets more clinical. I think the way people look at dementia is not only an amyloid beta or only an tau.
No.
So people with very high levels of tau amyloid beta can also be cognitively impaired.
Totally.
So when you're when you're thinking about the risk of a person for this project, are you going to combine and define the cognitive status of a person when you combine tau and
like with a score?
Yeah, like they do in clinic.
Yeah.
They have the combination of all this.
Yeah.
Determine, not just amyloid beta or just
yeah.
Just in clinical dimension.
Right. I mean, I think it's fair to say that the diagnosis of dementia is very complicated and takes years to diagnose. I don't know if we're going to have anyone within a 1-year period post-stroke that will develop dementia. You might get some in our study. So in terms of bringing everything together and coming up with a score of cognitive decline, I think it's feasible. I think I would probably be cautious doing that though, because then that's potentially crossing the line of like diagnosis. I'm not sure. Definitely speak with Mark about that. But if you're coming together with a score,
So you're asking if we're gonna do what Pedro does for these big trials, like neuropsychological combined with PET. We will not do that.
Yeah.
It's not possible.
Yeah.
We selected the blood. Remember, these are blood biomarkers. We're not talking about PET here.
Yeah.
Okay, so the
Yeah.
gold standard is PET.
Yeah.
But all these blood biomarkers, and we're not looking at them separately. We're also looking at the ratios. So we're looking at tau, but also the ratios, and there are 5,000 of those. And we spoke with Pedro, and Pedro suggested go for this one because they're the ones. But one thing I want to mention is the ADAS-Cog seems to be quite sensitive to capture MCI. I'm not saying this will replace psychological battery with PET, with the nurse, with the neurologist, with the meeting, because that's impossible. We don't have the resources.
You don't have can't wait, biomarkers as well.
May not be PET, but may not be PET, but
It's your outcome.
Yeah.
So that's why it's going to have special blood.
yeah.
I think what we're doing is like a couple things in the study. First is like primary outcome, looking at cognitive, but we're also looking at like pathophysiological underliers for cognitive decline, how exercise can impact it. So we're not necessarily looking at all of them together, but we're looking at things at mechanisms as well as maybe cognition. So I think that's the extent of the project.
no, I mentioned because it's the hypothesis is always increase. If it's an increase in A beta, it's going to be like increase in cognitive decline.
No, we're looking for associations.
No.
Okay.
Oh, yeah. I mean, I think what you could do eventually when you have all the data is you can do diagnostic cutoffs of the questionnaires and the biomarkers, right? You could do ROC analyses and things like that. That's when if you have a complete data set, because then you can dichotomize somebody based off of like the ADAS-Cog, mild cognitive impairment, no cognitive impairment, and then you can categorize like how their profiles are in terms of the biomarkers. You could do an ROC analysis doing that.
We want to extend the follow-up. This is super expensive. And have a random review and see but we would like to extend it. Like she mentioned this. 1 out of 5 patients will develop dementia in the first 5 years. It's insane after the stroke. So it happens really quickly. So it seems that the stroke really starts a cascade of. So we're going to capture perhaps some of them will be completely demented, but they will be showing signs of very clear decline.
I mean, they must be almost the changes start through years before until you start seeing symptoms. So changes in the brain.
But that's why we're using this questionnaire that you can criticize, but it's the best that I found. Because what if you have this underlying MCI and you have a stroke? How do you distinguish them? And this is what people are using now. And we have a lot of questions about it. Like, what if the proxy also has MCI?
Yeah.
No, everything is fine. But, so we have a lot of questions about this questionnaire, but it's the best questionnaire that I found to try to people that already
it's hard.
Yeah.
Yes.
Yeah. Hello.
My question, I know that the program after.
Yeah.
If by any the absent relatives or the spouse or whoever is with the patient is never involved in the treatment.
Yeah.
Because it's very often realized one or one member of the family deteriorate or whatever whatever it is. It is very difficult on the land. Yes, and also like
Yeah.
Guys, and then they go home, they're great, but what they get is that you have to play what the other person play. So it's kind of like the community starts within the household. It's especially more interesting for both.
Yeah.
And I say both because it's like a couple, like a couple. That they can actually continue and hear more the future. Longer.
Yeah, I think that's a huge consideration. If you want to promote adherence or self-management, training the caregivers as well as like on even providing them education on how to train safely, how to notice, good bad signs of exercise responses, I think is a huge next step, honestly. Like I think that's a whole other
The fact that you're not a scientist allows you to ask these beautiful questions that we don't think about. The problem is how you integrate this. Because if I would train with my partner, perhaps my cognitive stimulation would be different. Either worse or much better. So how do you control for that in this study? I don't know how to do that scientifically, but the question is super relevant.
And it's the same as and we're going to be more that participate in research, and they would say that I'm going to that they feel that the whole project that they have they're missing feedback throughout training. So are you planning to not only you're doing great, you're doing improving, you can see that, but more like a formal way of showing them the results throughout.
I think well, very educational in our very sensitive, not only to train them and use them for data, but to give them a report. I mean, that was a good example. Create a full report to teach people with Parkinson's how to sleep. So I think we're really trying. It's not only about research and getting data, it's to give them something when they leave so they know what to do at home. We could do better, yes. We could have more resources to we could have somebody going to their homes and helping them to decide on the bike and whatever.
I'm not saying that only because they feel that they're just guinea pigs, but also because it's part of the education. Right?
Yeah.
So they're training that they just are able to see on a paper that this is information.
We had feedback.
And it's really like what they're for people outside of research watching research, but they have no idea what getting presented. Like many of the slides are very difficult to understand. The only way to get closer to research is by seeing something you understand. So in this committee, we discussed this a lot because no matter how amazing the research is, if we look at the patients, we need to make sure that they get not only the results, but also they are able to understand why they have improved and how.
I think like we're not sending the report that we're making presentation, but I think we have improved. We can improve more, of course. We can do much better, yes. It's time, it takes time, it takes a lot of, but I think we care about the education. Taking the consent forms, we don't really know if we're in the study. I think we have them, if we want something. If you want to know. In fact, we don't have I think we class that. I think the process, I don't know. That's supposed to be.
But there's a difference between.
Bye, Veronique.
And a real finding that you.
That's true, that's absolutely true.